My name is Doris Hansen from Moffitt Cancer Center. Today I'll be discussing how pro-inflammatory state and peak cytokines are associated with toxicity and early response in patients receiving Idecabtagene Vicleucel. So Idecel is a CAR T-cell therapy, or BCMA, that was FDA approved in 2021. And essentially in this study, it was demonstrated that higher peak concentrations of inflammatory cytokines were associated with developing higher grade cytokine release syndrome, but no baseline associations were observed. And cytokines are essentially master regulators of the tumor microenvironment, as they represent the main communication bridge between cancer cells, tumor stroma, and the immune system. So the purpose of our study was to study the association or the effect of cytokines in a pre-CAR T bone marrow composition with toxicity and response in patients receiving Idecel at Moffitt Cancer Center. So this was a retrospective analysis, and patients were consented to a biospecimen protocol. We measured a series of cytokines and inflammatory markers. For cytokines, we used the LA immunoassay. Our cohort consisted of about 86 patients. 1/3 of these patients had high-risk features like they had high-risk cytogenetics, they had a high plasma cell burden, which was defined as having more than 50% plasma cells in the bone marrow biopsy pre-CAR T, and also had penta-refractory disease. But also I'd like to point out that this population was different in the KarMMa clinical trial, in the sense that 72% of the patients would have been trial ineligible. Safety profile was very similar as what was seen on trial. We did see that patients who were 65 years or older were more likely to develop any grade cytokine release syndrome and neurologic toxicity, and we did have 3 deaths related to myeloma complications by day 90. We also looked at the association of serum cytokines with any grade cytokine release syndrome and identified that higher peak concentration of inflammatory cytokines were associated with developing cytokine release syndrome. For grade 2, it was only an association with higher grade or higher concentration of interleukin 6. For neurologic toxicity, we found some cytokine associations at baseline. So TNF alpha, or tumor necrosis factor alpha, was higher at apheresis, while interleukin 15 and angiopoietin 2:1 ratio were higher for patients who developed grade 2 or more neurologic toxicity at day -6, and higher peak concentrations were observed for interleukin 6, interleukin 15, and angiopoietin 2:1 ratio for patients who developed grade 2 or more neurologic toxicity. We also observed that baseline ferritin was higher for patients who developed neurologic toxicity of any grade and grade 2 or more, and peak concentrations of CRP and ferritin were higher for those who developed CRS and neurologic toxicity. We also identified an association with Idecel response, in particular patients who had higher concentrations of interleukin 2, GM-CSF, tumor necrosis factor alpha, interferon gamma, were more likely to achieve a partial response or better with Idecel. This was consistent for best response rate, as well as similar for complete response or better. We also found an association with cytokines and tumor burden or systemic inflammation in particular. So patients who have a high tumor burden were more likely to experience systemic inflammation, as was noted by higher concentration of inflammatory cytokines, as well patients with a higher baseline ferritin and peak ferritin. Those patients were more likely to have a high neuro burden or plasma cell burden. In a subset of patients, so 35% or 35 patients, we were able to perform a bone marrow biopsy pre-CAR T to immune cell phenotype T cells, myeloid cells, and natural killer cells. And essentially, we're able to identify that in patients who have a high plasma cell burden, these patients were more likely to display markers of T cell and natural killer cell exhaustion, in particular CD39 among CD4 and CD8 T cells, and T cell immunoglobulin with ITIM domain among CD4 T cells, and a higher expression of CD56 DIM natural killer cells, which may lead to impaired activation, proliferation, and upregulation of inhibitory immune receptors. So in sum, high plasma cell burden is associated with systemic inflammation, which may lead to immune dysregulation, which may impact T cell function, fitness, and ultimately CAR T product. In conclusion, the study demonstrated that cytokines and pre-CAR T bone marrow composition do appear to be associated with toxicity and response, and hopefully this provides some early insight into potential avenues for toxicity prevention and therapeutic optimization to improve efficacy and reduce relapses. And certainly larger studies with larger amount of patients and follow-up are required to better understand the relationship between inflammation, immunity, toxicity, and response. Thank you very much.